please.
Thank you very much, and good afternoon, everybody. And it's like 2:30. This is the time when everybody's blood sugar is going to start peaking, feeling hot, cozy room. So I'm going to try to make this, as informative as I can, and hopefully this will resonate with you. So thank you so much for that kind introduction. What we need to do is, so in my population of smokers, that actually is your population of smokers now, through my program and study going on with the STOP program. How many of you are familiar or participating in STOP? Okay. Wow, that's great. Thank you. So roughly there are 50,000 people going through. 86% of family health teams are participating. But what I can tell you, rough cut, of the smokers who are coming through that group, 50% will say that they've had a lifetime history of a mental illness. So we know that whoever's coming through your practices are not your healthy smokers. And interestingly enough, when you look at the whole population of who's quitting, having a mental illness, because we do follow-up. We follow up at 3 and 6 months and find out what's happening. It's interestingly, there's no difference. Having a mental illness, within that program, whatever you're doing with the counseling and your staff and whatever you're doing, is the quit rates are the same for those with and without mental illness. Your patients with chronic disease, which is another 50% approximately, have one or other chronic conditions. They too are not having any difference in their quit rates. So it doesn't appear that the chronic disease is interfering. It isn't like it's too many things going on for them. What is fascinating is if they have smoking, mental illness, and a chronic disease, then they're not quitting. So it could be burden. And there's another emerging trend that we are seeing from this in terms of smokers coming through, is that there are smokers who are pretty much, I follow up on every death in the study. And basically the people who die actually were going to die anyway. These are people who actually have end-stage conditions. They have end-stage COPD or they have end-stage cancers, many of them, and they're still coming to participate. So we're really fascinated because not many people have reported that people with these conditions want to quit, but they are coming through your program, through your clinics. And this is very interesting because right now we're beginning to understand that when you take a look at cancer patients, even after diagnosis of cancer, smoking cessation is improving response to chemo, response to radiation, response to a whole bunch of things. But primary care is where it's at. And one of the things that we're beginning to see is that patients, our current smokers who are coming through, are much more likely to have mental illness. So how do we change how we treat them? And before I get into that, I obviously want to make my disclosures known. So these are my grants, people who I've worked with. I've worked with all the manufacturers of stop smoking medications, including one company that was developing a vaccine, which, the first iteration and that whole first group of companies that try to make vaccines has failed. But I think there's something still there. It'll resurrect. There are just different ways. We had a problem with antigenicity of the vaccine, but that's going to happen. And so these are the people I work with. I don't currently work with any tobacco, alcohol, or food industry funding and never have. But these are my disclosures. I will be talking about medications, and some of them might appear to be off-label. I might be off-label, but they're not without evidence to back them up. So what do we want to talk about today? What I want to really cover in the next 20 minutes is that there is a relationship between being addicted to tobacco, mental illness, and other addictions. These cluster in the same population. Secondly is you are going to have these patients in your population, but as we know now, that if you took a backseat and said, well, we can't deal with their smoking because they've got too many other things going on or they've got this other illness, we know that if we just stand by and do nothing, these patients will die at least 25 years earlier. And that's been proven. People with schizophrenia died about 25 years earlier than their counterparts, primarily from smoking-related illnesses. So essentially, mental illness strikes young people, and if they're smoking, and they'll come to see us in family medicine repeatedly, the question is, if we're going to take a whole person approach, we can't just say we'll pay attention to one piece of this, but not the rest of it. Because if that was the case, then they might as well just go see specialists, right? Why come to a family doctor? So that's one thing, is to think about how can you take a whole person approach to the patient, and how do you prescribe medication safely? Because clearly you have to not do harm. How do you prescribe medication safely to patients who might have a potential risk? How do you balance those risk benefits? Ross was talking about risk versus benefit. Well, now we have to balance those risks versus benefits to that individual, both the short-term benefits and short-term risks with the long-term benefits and the long-term risks. So it means we have to think. It's a little hard, right, when you've got 30, 40 patients going through, but hopefully when you're in a situation like this, you can reflect on it, so in the moment it becomes easier to decide. And then let's look at what kind of dosing adaptations may be required to help people quit. So this is what it is. In roughly, if you know, bottom line, if you've got a patient who is smoking above the usual average Canadian amount, which is about 16 cigarettes a day, and is still smoking, getting into their 30s, 40s, still hasn't got the message, think about what is going on. That is, just don't, put it down to they're just addicted, there's nothing else. It might be true, but there's a lot more going on if somebody continues to smoke, Because the prevalence of smoking in the clinical samples, if you take a look at it, generally it's about 2 to 3 times that what you would see in the general population. So the general population has had a nice decline. This population continues to stay pretty high. And again, if you take a look at this, the illnesses that are most highly associated, of course you'll hear about schizophrenia, but the one which is even more is actually alcoholism. And alcohol and tobacco together have a multiplicative risk for all aerodigestive cancers, including cardiovascular risk. Somebody says, well, I'm drinking wine so that I can reduce the risk from my smoking. That doesn't kind of work out really. They're not doing that, right? So, of course, these are the common reasons people will get. Well, I smoke because it's my mental health. And you know what? I believe that because, I was practicing full-time family medicine at St. Joe's till about 2000, and then I was asked to come to CAMH at the time to set up basically a smoking cessation program for people with schizophrenia. And people say, like, are you crazy? That's the only pleasure they have in their life. But all I did was listen to the patients, and I can tell you, it didn't sound like fun. And it didn't sound like fun to them either. It was just the assumption that everybody had made. And in fact, as you started looking down, it was in fact, 15 years later, what we know now is that it may be a reverse causation. It isn't necessarily that people are smoking because they're mentally ill. They may be getting mentally ill because they started smoking. And they're vulnerable to those 7,000 chemicals, 60 carcinogens present in smoke. Many of them psychoactive. So to think it's the other way around may have been a fallacy of medicine. So anyway, we'll stop there with that thought, but just keep an open mind that there may be a bilateral vulnerability. Secondly is that our patients with mental illness are dying from the smoke. They're not dying from the nicotine. The nicotine is not what kills them. It's the smoke that kills them. Now, I'm not suggesting that nicotine is 100% safe, but neither is the vehicle that you traveled here in either. Neither was that Starbucks coffee that you got this morning, right? Or the beer you're going to have tonight, or the scotch you're going to have tonight, whatever it might be, right? Nothing is 100% safe. And neither is any of the medications we prescribe. So we've got to put this into perspective. The issue is that when people with mental illness smoke, it interferes with their medications as well. It's huge kinetic interactions with their schizophrenic, or with their antipsychotic medications, their benzodiazepines. So there are really some things to consider in this patient population. Now, we talked about this, of why they die, and mainly because of smoking. And again, a very high rate with people who have other addictions. Now, I talked a little bit about this, and so I'm just going to move ahead because we only have about 20 minutes, and I want to make sure we have time to discuss things in terms of how to actually do this. You'll notice that people smoke a lot more. So if you often offer them just standard treatment, especially when you're using things like nicotine replacement therapy, and you're trying to match somebody with what you're smoking, Putting a standard dose patch on somebody smoking like 40, 50 cigarettes a day would be like you coming up to somebody who's got a gaping aortic wound gushing out and saying, oh, let me pull out my handy Band-Aid and let's see if we can stop the bleeding, right? It's not going to do the job because you've got a deficit replacement. Just very simple pharmacology. You've got deficit replacement. So the more somebody smokes, the more standard treatment you use, the less likely you're going to replace their nicotine replacement. And generally, we know that if you're not replacing approximately 60 to 70% of the nicotine, you're not getting them anywhere next to being quit.